Okay, I think we will move on with one quick presentation from me. It will be, cataract and irregular astigmatism. I will just try to make it only 5 minutes and give Bruce also another 5 minutes for his last talk and then go for the videos. Irregular astigmatism. I will just make 5 crucial points and I will skip the rest. Before doing any surgical operation, we have to be sure that there is a stable disease and that we know the stage of the cornea before start choosing what kind of lens we're going to put in. Because we have all these problems, it is difficult to identify in all irregular corneas, and by saying irregular corneas, irregular astigmatism, I include keratoconus, keratoglobus, cornea graft, and post-refractive surgery, laser refractive surgery cases. Choose the right formula and choose the right selection of the IOL. We have a lot of problems, and basically most of the problems start from the corneal power, because simply what we use as a corneal power in the first formulas is an erroneous refractive index, which doesn't imply with what exactly is happening. Also, especially in keratoconus, we have a paracentral visual axis, which is very important to take care of. In cases of keratoconus, please don't forget the surface distortion and the tear film irregularities, which are extremely important when we're going to take care of the keratometry. And also, as we said before, the postoperative result relies on a good ocular surface and a good tear film. And the other thing is that the AC depth is also significantly deeper than the standard eyes. But also axial length is very big, very large in keratoconic, especially in keratoconic eyes, but also in myopic eyes. So take care that you're going to measure the axial length without any problems, and especially when you're going to have paraaxial visual axis, which is a bit of a problem in these cases. Of course, the 4th generation will be ideal, but what studies showed is in the beginning, maybe SRK2 will be quite good in very, very abnormal corneas. So don't just reject the older formulae, because they may help you in these unusually irregular corneas. Another rule is to follow that up to 55 diopters of central of K max, and whatever is more than 55, just use standard IOL. So this is another thing to keep if you don't have special equipment. And by talking about special equipment, I'm talking basically on equipment that can give you the results of the posterior surface, and these are basically Pentacam, Orbscan, and the new OCTs. So, per number 2, significant variability between different methods. Usually, if you follow one of these methods and not including the posterior surface, you're going to end up with a hyperopic shift, and that is a bit of a problem. Try to aim for the myopic shift, because that will be easier to correct later, either with excimer laser or with contact lenses. And I cannot stress more the importance of the posterior surface. Whatever you use, either the true corneal astigmatism, the true net power, whatever, please consider these as your standard cornea power that you're going to put in your formulas. It is very, very important to use the posterior surface, and this is probably the best tip I can give you. What about IOLs? Spheric, toric, multifocal, whatever. Torics, although there are a lot of discussion, whenever they used torics, the result was always better. The uncorrected result was always better compared to the standard lenses. And this is something that we all agree. But actually, are all the lenses good? Or let's say, are all the corneas good to use toric lenses on? The answer is no. You have to use a toric lens in a cornea which is irregular but somehow more regular than the very, very advanced cases of keratoconus. What we do in these cases, there are a number of things to do. You may use some ways to regularize the cornea, and that means either topography guided plus cross-linking or rings before the operation, and then re-estimate the cornea power. And in cases of progressive keratoconus, because we do have cases where we have cataract and the patient's age is still young, consider cross-link the cornea first and then proceed for your toric IOL or for your cataract operation, simply because, as I said, rule number one, consider that your cornea that you have is stable. If it's not stable, it will result in a different kind of surprises post-op. So aim for myopia. You may have a low residual astigmatism, which may be beneficial for the patient. Usually, the corneas of keratoconic patients are multifocal corneas, so it's very interesting that. What about toric IOLs again? Look at the location of the ectasia. If the location is central, I think you can use safely a toric IOL. If it's too paracentral or too eccentric, then I think it's going to end up in disaster. And pellucid marginal degeneration are perfect examples to use for toric lenses. And these are some of the results of our studies. I'm not going at all to just want to tell you one thing about possible other choices of IOL. As I said, trifocal is out of the game. We will never use trifocals. It's a very complicated optical system to put in front of another complicated optical system, such as a trifocal. But for an early keratoconic stage of a central keratoconus, you may consider an EDOF lens. I have seen one case that I put in a very young patient, an EDOF lens, and recently in the Journal of Cataract and Refractive Surgery, one of the famous cataract surgeons, Samuel Muscat, also reported another case of EDOF. Use it with extra care. Do not start with this, but certainly in some cases you may consider it. What else? You may consider LAL in these cases. LAL are the light-adjusted lenses. Light adjustable lenses. What do you do with those? You implant it, and then you will have a chance to refixate, to rectify, to reduce the amount of astigmatism every 10 days just by applying light and then changing the shape of the lens. I think it's a very, very interesting option. If you have it, it's a very expensive lens, but I think for these special cases it might work. And as I said before, a very interesting option as well is this lens that you see here, the AccuFocus with a pinhole, where you don't care at all about all these irregularities of the peripheral cornea. You're only focusing on the center. These are probably very good lenses, and I'm looking forward, once we have them in Greece, to use them in the keratoconic patients, because I think they do have an advantage over all the other. And with that, I will finish. I will ask Bruce to give us the two last tips.